Alright, welcome back to our ongoing video series in using Medusa's Siren ePCR software. In this video we will discuss the recording of vital signs that you obtain during your treatment of patients. We will also discuss how you can record various scores that you may collect in your care, how to document fluid input and output, and how to document ECG monitoring interpretation. This can all be documented in the Vital Signs tab at the bottom of the screen. When this tab is selected, you'll see the previously 4 sections mentioned on the left-hand side of the screen. Starting with Vital Signs, you'll see I have an entry that I have previously typed in. If I want to create a new entry, I just press the plus symbol, which creates a pop-up window that is time and date stamped for the moment I press that plus symbol. Done by is auto-populated by whomever is signed in as the primary attendant. If you would like to document that your partner or a sending hospital nurse or some other person on scene provided this vital signs assessment, then you need to select that box and make that change. Patient position can be documented. If the patient's position is not able to be documented using one of the pre-selected options, then select other and free type the position the patient was found. Glasgow Coma score can be documented by pressing the GCS box. A pop-up window will appear where you can choose the best option from eye-opening, verbal response, and motor response. It is then totaled, giving you your total Glasgow Coma score. If the patient's intubated or sedated or their eyes you are unable to assess because they're, for example, swollen shut, you can provide a qualifier in the same section. Heart rate, select the box and manually type in the patient's heart rate. In the details section, the 3 options that are listed, transcutaneous pacing, transvenous pacing, and fetal heart rate, are primarily for use by our air ambulance team. However, if you are providing transcutaneous pacing for your patient in an advanced life support setting, you can select the rate that you are pacing the patient at, for example 70, and then you can put the qualifier that is via transcutaneous pacing. Transvenous pacing and fetal heart rate again would be primarily used by our air ambulance team. Blood pressure, systolic, select the box, enter the blood pressure, and then you can press the tab button or click on the box for diastolic with your stylus to move the cursor, where you can also enter the blood pressure manually. Select the location that you are obtaining the blood pressure from and the method you are using. You'll notice on the line below the map is automatically calculated. Respiratory rate, much the same. In this section, details, you have ventilator, BVM, or spontaneous, so you can describe whether that respiratory rate was provided by either of those 2 devices or if it was spontaneous. Oxygen saturation, you can describe whether it was unable to obtain room air or on oxygen. And tidal CO2, you can describe whether it was continuous, unable to obtain, or equipment malfunction. Glucose, you would manually type in. Temperature, you would also manually type in. And you can describe how that temperature was obtained, in this case PO. Pain numeric, we would like to see an assessment of all patients' pain levels and then that documented in the vital signs section for all patients at least 1 time. If your patient has no complaint of pain, then you would document 0. If your patient has any pain, then you would document whatever they give you for an answer when you are questioning them on their pain in relation to the numeric pain scale. If they are unable to provide a number, you can utilize mild, moderate, or severe. We would expect to see at least 1 entry of 0. If there's no pain, that's sufficient. Airway pressures are not documented in this section. If you are using a mechanical ventilator, they are documented elsewhere. Ignore this box. Peak flow, if you are obtaining a peak flow in a primary care clinic setting, that can be documented. ART systolic and CVP, I would discount either of these boxes. They are relevant only in the critical care setting. Once you have finished making your entries, you can press the Save button, where your new vital signs entry will be listed with any previously made vital signs entries. If you want to open and edit any of those or add more information, you can simply select it and then double click it, which will open the window for you to edit. Scores, if you press the plus symbol, you will see a pop-up window, time and date stamped, populated by the primary attendant. You can list the CTAS of the patient from on a scale of 1 to 5. Just click the box and then manually enter the CTAS. PHI, when you press that box, you'll get a pop-up window where you can enter all of the various components of the PHI. PHI is pre-hospital index. Pre-hospital index is only relevant for pre-hospital trauma. If your patient is not complaining of pre-hospital trauma, this box can be ignored altogether. If they are complaining of pre-hospital trauma, then you can enter the score in the various categories, which will give you a total PHI for the patient. If you're using a Broslo tape, you can describe the Broslo tape category. If you are dealing with a newborn, you can utilize, you can enter the APGAR. And if you have a burn patient, you can enter the burn percentage, the percent burn surface area. And if you have a MEMCI, you can enter their start triage category. Once you have finished entering, press save, and you'll see that it then lives with any previously made entries in the score section. Input and output functions the same. Select input and output and then press the plus symbol. You have a pop-up window, time and date stamped, populated by the primary attendant for done by. For input, you have the option of describing any input and any fluids that was administered that were crystalloid, colloid, oral fluids, or blood products. And for output, you have the option of describing urine output, estimated blood loss, emesis, nasogastric tube, or measured blood loss from Pleurovac, for example. We would like to see in all patients, if there was no fluid administered, 0 fluid, just type 0. If the patient did not void, if there was no output, then for urine, type 0. That ePCR considers this I wouldn't say a mandatory field, but it is a field that it will bring your attention to if there is nothing entered. If you administer a fluid bolus, then take the time to write down an input that, yes, I administered a 250 ml bolus. If I administered 125 mLs per hour over the span of 2 hours, then I would denote that I administered 250 mLs. Fluids are then totaled for your total input, and the same occurs for output. If you have a patient with a Foley catheter and you are measuring urine output, you may measure it every few hours and then drain it. That can be entered in, and then you can get a total fluid output. Finally, ECG monitor. This is where we would document our interpretation of any obtained ECG rhythms, whether they are rhythm strips via limb leads or 12 leads. To do that, with the ECG monitoring section selected, select ECG interpretation and press the plus symbol. You get a time and date stamped entry. Amend the timestamp or the date stamp to reflect when the ECG was obtained, and amend the done by to reflect who obtained the ECG. Describe which leads were assessed. In the example of a patient where you just did a rhythm interpretation via limb leads, I may have only looked at leads 1, 2, 3, AVF, AVR, and AVL. I may note that the patient has no significant ECG changes, examples being ST elevation or depression, Q waves, left or right bundle branch block, peak T waves, or a widening QRS. I am doing a 4-lead ECG. I may note that the underlying rhythm is a normal sinus rhythm. There are no other underlying rhythm details I would like to describe. There are a variety of rhythms that I can choose from. No underlying rhythms that I'd like to describe, no ectopy that I would like to describe, and therefore no ectopy details that I would like to describe. In the comments section, you have the ability to include information if you feel it's relevant, such as you might want to document the PR interval, or the QRS width, or the QT or QTC, or the QRS axis. That depends on how nerdy you want to get with your ECG interpretation. That's not an expectation, but you certainly have the freedom to do that. Once you have finished interpreting your rhythm, you can press save. say, for example, you obtain a 12 lead and it is your expectation or within your scope of practice to interpret that 12 lead. You would do another entry, time and date stamp, done by, etc. And then you would select all the various leads that are looked at in the evaluation of a 12 lead. Maybe you see ST elevation in this 12 lead, and maybe this patient is presenting with sinus bradycardia. There is no underlying rhythm details to describe. There is no ectopy to describe. There is no ectopy details to describe. What we would like to see, however, if you do see any changes on the ECG, specifically ischemic changes, we would like to see you describe ST elevation noted to leads to, I'm going to change this, V4 through V6, 2 millimeters, no other changes noted. So now the reader will look at this entry and they will see that you have interpreted the ECG at this time to include ST elevation of 2 millimeters to these leads with no other changes noted. That's important information to pass along. Whenever you do a ECG rhythm interpretation, if it changes from the baseline or the initially entered rhythm, then we would expect you to include an entry describing the changes noted. If, on subsequent ECG evaluations, there's no changes, then there's no need to create a new entry outlining the same rhythm was present. Okay, that concludes this lesson on the Vital Signs tab. Thanks for watching, and I look forward to talking to you in the next video.